Good afternoon, everyone. My name is Pananya Lapasatpan, a provisional counselor at the Mental Health Foundation Australia. I begin by acknowledging the Wurundjeri Woi-wurrung people as the traditional custodian of the land on which I live and work, and pay my respects to them, their culture, and their elders past and present. On behalf of the Mental Health Foundation Australia, I would like to welcome and thank each and every one of you for attending the depression webinar. I would now like to invite our presenter, Professor Malcolm Hopwood. Professor Hopwood is an Australian academic psychiatrist affiliated with Ramsay Health Care and the University of Melbourne. He served as the Ramsay Healthcare Professor of Psychiatry at the University of Melbourne and is based at Ramsay Clinic Albert Road in Melbourne, Australia. Professor Malcolm Hopwood completed his medical degree, master's, and doctorate at the University of Melbourne. His doctoral and postdoctoral research focused on the blood-brain barrier and pharmacogenetics. He subsequently founded CNS Dots, a successful spin-off company that received funding from the University of Melbourne and the Texas Medical Center before merging with a larger diagnostics firm. As an author of both the 2015 and 2020 Royal Australian and New Zealand College of Psychiatrists Mood Disorders Clinical Practice Guidelines, Professor Hopwood has contributed significantly to the field. He has over 100 academic publications while maintaining a full-time clinical practice. Professor Malcolm Hopwood established Australia's first regional clinical repetitive transcranial magnetic stimulation, or RTMS, service, which continues to operate in 2008. Professor Malcolm Hopwood is an author of the 2020 Clinical Pharmacogenetics Implementation Consortium Guidelines on Antidepressants and has served on the Genetics and in Psychiatry Task Force for the International Society of Psychiatric Genetics. Professor Hopwood remains committed to improving patient outcomes through scalable, affordable mental health innovations. So please join me in welcoming Professor Malcolm Hopwood.
Thank you for that. Just a small correction there. I'm not quite sure where that came from, but I'm not the founder of CNS Dose or an owner, just to be clear about any conflicts there, but that's okay. Don't think that changes things too much. Oh, excuse me. And a pleasure to be joining everyone at lunchtime. I know. It'll be even better when I have a clear throat. Just excuse me. That's a bit better. So, a pleasure to join everyone again. I've got a presentation with a few slides about both current and new treatments in depression. And then I'd like to leave lots of time for question and answers. And I know I've received a few pre-questions, which is great. So really happy and looking forward to that bit. No? There we go. I think probably with this audience, I don't need to stress it too much, but there's always the why are we here question. And I think at the end of the day, we're here because depression is the leading cause of mental health related disability. And the latest burden of disease study globally says it's one of the leading causes of disability of any health condition globally. And that's a huge thing to think about. Quite rightly, we often think about it at the level of how it's affecting me, my family, my roles. And it can feel a very lonely battle, I think, at times. It's important to acknowledge that this is a common disorder. More than 1.3 million Australians live with depression. That's per annum. And if we look across the lifetime risk, it's 1 in 5. If we look at the numbers affected globally, they're enormous. This is not a rare condition, and that's really a challenge to us, isn't it? Because we need to be as good as we possibly can be at treating it, and ideally even better than we are currently. Um, we know that part of the reason depression causes that high level of burden is because it's a significantly recurrent condition for some people. And that's a situation we don't want to get into. And each time you have a treatment, your chances of response go down and your chance of relapse goes up. Now, that doesn't mean if you've had multiple treatments, we can't still find something that works. We can, but we really want to up the urgency here, don't we? To get people onto the right treatment earlier, to really prevent this becoming a long-term cause of disability. It's interesting, we've had a bit of kickback in recent times about both the mental health care system in Australia more generally, but also the level of prescribing of things like antidepressants. So these are figures for the utilisation of mental health services across Australia. And I'm not telling anyone new news to say demand for mental health services has escalated hugely over recent decades and seems to be continuing to increase. Now, part of that is a recognition that problems like depression are real. And thank goodness people now feel much more able to present for care. And that's a good thing. Um, Part of it, arguably, is are we making all this activity as efficiently and as evidence-based and organised as it could be? And I think lots of people with evidence to things like the recent Royal Commission in Victoria would say, yeah, maybe not. Are people getting rapidly to the right care in the right place at the right time? Not perfectly, despite all this effort. So part of what I'd like to address initially today is, well, what are the right first steps? What does that look like? There's a tremendous preoccupation at the minute with new exciting treatments, the ketamines, the psychedelics, and so on. And that's all good and relevant. But actually, for most people, if we get the first few steps right, the chances are pretty good. Not 100%, but pretty good. So we really need to focus on them a bit. I just love putting in bits of art when I talk, and there's no particularly good reason to put this in, but they're beautiful bits of art, aren't they? Some of you will, of course, recognise these are the work of Vincent van Gogh. The one on the left is entitled Melancholia, and I think it portrays as much as a single image ever can the human suffering that is part of depression, and that's to be acknowledged. Um, the right was, of course, drawn when he was in Arles, at the asylum in Arles in France, where tragically his life ended abruptly. And I think for those of you who have an interest in sort of historiography, I think there's little doubt personally that he had bipolar disorder, just out of interest. But I think more than any other artist, I think, he was able to capture some of the mental state of what it's like to suffer from depression, albeit it's not the same for any two people. One of the commonest questions I get when I talk in community settings about depression is the crossover of depression with so many other disorders, in particular anxiety. And the first thing I want to say is, yes, that's right. That we often talk about depression like it's this isolated thing. And probably that's true only in about 10 to 15% of cases. So many people with depression have other disorders and other problems. And it's really important for us to acknowledge that, to assess really carefully for those problems, and then plan sequential treatment appropriately. To take a classic example, when I see people with depression, a very high proportion, probably 70 to 80%, also have anxiety going on at the same time. This study says that if you have the combination of depression and anxiety, the impact on your functioning is much, much higher than depression alone. And that's not surprising, is it? Makes sense. And can be part of what's really difficult for people about depression. How do I approach that clinically? Well, my primary focus will be getting the depression right and then seeing whether the person is left with an anxiety disorder when the depression's better. That's important because often if you've got anxiety badly as part of depression, that's what can cause people the most distress. And they really want that looked after. I get that. But let's not forget about treating the depression because you may be one of the ones when we treat the depression, anxiety goes away. Or you may be one of the ones who we need to treat anxiety in its own right once the depression's better. Those same sentences could go for a lot of other comorbid problems. A common one we're getting now is, do I have ADHD? As well as depression and anxiety, with all the complexities of what's chicken and what's egg. If someone's got a good going depression, can that affect their concentration? Yes, of course it can. And sometimes, just like anxiety, it can be difficult to know what's primary and what's secondary. If there's a clear history of ADHD going back to childhood with the classic school reports and all of that stuff, fine. And sometimes we'll say, well, look, let's get your depression treated and see where that leaves us at the end of that. Part of the importance there is going back to get reviewed once the depression's better. The human tendency is once I feel better, I'll just move on and won't worry about it, including stopping either pharmacotherapy or psychotherapy too early. Don't do that. Go back, sort the problems out. Now, we have good data that says 50% of people stop taking an antidepressant in Australia within 3 months of it being prescribed. This was actually in people who were fully subsidised, so money wasn't the issue. Actually, it's data about did they pick up a script. So just because you pick up a script doesn't automatically mean you're fully taking it, does it? Now, no guideline recommends you take an antidepressant for 3 months after an episode of depression. Most would say after the first episode, 6 to 12 months, something like that. So people aren't doing kind of what we as doctors think people should. Maybe that says something about the doctor. That's quite probably right too. But interestingly, it's not just medications. We have a lot of debate about the number of sessions that people are eligible to get out of the Better Access scheme with someone like a psychologist. And that's a good debate and should be discussed. But actually, the average number of times a person does see a psychologist under Better Access is 3. So the whole debate about is 6 enough, which is absolutely true and relevant for some people, isn't what most people do anyway. As soon as they start to feel better, they stop therapy as well. Now, it might be for other reasons. Maybe they didn't find it useful or whatever. But we've got a big problem that the first step in really getting that surge in treating this problem better is to get better agreement about what treatment looks like and getting people to adhere to it. What's the problem there? Well, there's probably lots of problems. That's probably true. One of them might be this. This is a study from Kund-Mettner, a European study that echoed previous American studies that said, actually, what the doctor's looking for in the treatment of depression, or the psychologist or anybody else, might be different to the patient. So we're trained to look at the classic symptoms of depression. And in deciding is a treatment working, we'll often go through a bit of a checklist, whether it's a formal rating instrument or at interview, ask about mood, sleep, appetite, energy, motivation, And they're all relevant. But actually, when Kun asked to a patient, what's most important to you in feeling like you're better from your depression? They were slightly different things. The top ones, and these are in order, were a meaningful, enjoyable life, feeling satisfied with it, and the classic symptoms were a little bit less important. So are our conversations sometimes missing the point that what I'm thinking is important in judging if things getting better and what you're thinking is important, we're like ships in the night. So an important part of good care is working out our goals together early on. It's a difficult art sometimes, because when you're feeling very depressed, knowing what your goals are isn't always easy, is it? But getting a shared sense of where we're trying to head would be a good start. There's then the issues about what treatment might you prefer. Now, this is a very interesting area. People do have views about which treatment they prefer. Particularly in this day and age, there's so much information out there about treatments, sometimes almost too much, I sometimes think. And it's hard to sort out the good quality information from the rest sometimes. But people often have strong views amongst the initial treatments about whether they'd like to try therapy or medicines or both. In most countries across the globe now, not just Western countries actually, if you ask people, there is a population preference for therapy. It's not 100%, but more than 50%. It's interesting, isn't it? And I found recently on a trip, this was true even in China. So true in some of the countries you might think would be different. Not at all. Does it make a difference if you get the treatment you want? When you say that out loud, you'd think, oh, I imagine it might. Well, this is a very interesting Taiwanese study. It's quite old now. And it did a simple thing. People with mild to moderate depression were randomly allocated to get either medication or structured psychotherapy like CBT. And the primary outcome was comparing which one worked better. And actually, overall, they were pretty much the same. And subsequent studies have replicated that lots of times for mild to moderate depression. But before they were randomly allocated, people were asked, would you prefer medication or therapy? And then at the end, the data was analysed to say, well, if you got your preference, did it make a difference? And actually, yes, it did. So if you got your preference, whichever one it was, at the end of the study, on this Hamilton rating scale, you were about 5 points better off than a person who didn't get their preference. Now, we would say 5 points better off is a clinically big difference. So working together to work out your goals and your treatment preference is helpful. Now, there are going to be circumstances where that's more complicated, isn't it? So someone who has severe forms of depression where they can't decide, or whether they feel that there's no point in going on, that might alter that balance, mightn't it? But that's out at a particular edge of our difficulty. In guiding us through these first steps, then, we take into account shared goals, preference, but then how do we decide based on the evidence? Because many people are going to say, well, what do you think, doctor? What does the evidence tell me about different treatments and what I should do next? Because there's so many things on offer now, right? How do I decide? These are the most recent, albeit 4 years old, guidelines from our Royal Australian New Zealand College of Psychiatrists about the treatment for mood disorders. And I'm going to focus on those bits relevant to depression. If you want the most recent international guidelines, the CANMAT Canadian guidelines were republished in 2024, and they're probably very well known and probably the most recent. Are they fundamentally different in most of the things I'm going to discuss today? Probably not too different. There are some subtle differences, but probably not too different. I'd like to acknowledge my co-authors who clearly carried me along in the process, so thanks to them. So we divided treatment up this way, and this is a slightly different way of looking at it. We said there is a set of actions that everyone who presents with depression should have an opportunity to access. They include psychotherapies and lifestyle changes, and we'll talk a little bit more about them in a minute. We then said there's a set of choices, and this is basically starting with medications. In essence, we're saying they are optional for most people presenting with depression, not mandatory. Previous guidelines talked about in mild to moderate, you might start with therapy, moderate to severe, you'd always start with medicines. And we'll talk about the evidence for that, but we've also tried to pitch it towards people's preferences. Of course, is there a risk, given what I've said previously, that if you go and do one thing first and delay starting medicine, that you could drag the whole thing out more? Yes, there is actually. Is there any problem with combining them from the start? No. I always thought when people would argue about which one, thought, well, what's the problem here? What's the problem with doing both? And in fact, we now have clear evidence that the combination does give the highest remission rate, which is valuable. There's then a set of alternatives that we use if those first few steps are not getting things better. This would be where the medication combinations, stimulatory treatments like TMS and ECT, or even the new therapies like ketamine and psychedelics might fit in. And we'll come back to those. So there is a tiering, and that's important. This tiering is based on evidence. And we thought our job as experts in this area is to help people interpret the evidence. Because sometimes what you pick up from the evidence from whichever newspaper or article or online forum can be misleading, can't it? Well, that study sounds exciting in 10 people. How do I place that in the bigger scheme of evidence? And what are the risks and benefits of that treatment for me? That can be really difficult when you first come across that sort of evidence, I think. Just a comment about the lifestyle stuff. This is a combination of things we would use to help depression directly and those things that are also about looking after your physical health, because we know that physical health risk is higher in people with depression. Sometimes that's part of why they're depressed, but it kind of can become an ongoing cascade. There is now reasonable evidence that exercise and diet can be helpful interventions in combination with other therapies. Now, the exercise we're talking about to be an effective antidepressant is relatively vigorous, up to 45 minutes vigorous exercise 3 times a week. Is walking around the block helpful? Yes, it is, in probably other ways. But to really be an antidepressant exercise level, it's got to be pretty vigorous. The diets we're talking about, the most evidenced is the Mediterranean diet, but speaking to those people who are experts in this area, like the Food and Mood group from Deakin, that's about good diet. And we know that for many people with depression, either for a long time or just recently, diet is not so great. Things like alcohol and cannabis, and we'll come back to that, and other substances of abuse can induce mood disorders like depression. So every time would I say, stop those things? Yes, I would. Now, with things like alcohol, there's an interesting debate. Is there a safe level of alcohol use while I'm depressed? Well, maybe just, but it's not going to be as much as you'd like it to be. And of course, we need to be mindful of interactions with medicines if you start those. But it might be if you want to have a glass of wine a week. I really, just to put it in the ballpark. So when I say alcohol can worsen your mood disorder, I do mean it. The There's a whole set of other social variables that, of course, can cause depression or worsen it. If you're struggling with poverty, discrimination, lack of housing, for goodness sake, relationship difficulties, we should ignore them at our peril. Of course, they're associated with a higher risk of depression and are going to make it worse. And whether I can deal with all of those problems or they're easily soluble, I should never ignore them and help you to get the assistance you can, and sometimes help you to get better so you're better able to deal with them as well. But never ignore them. That's just would be ridiculous, wouldn't it? Why did we say everyone should be offered therapy? So traditionally, guidelines have said severe depression therapy is too difficult. Well, that's probably true at a very, very severe end, that we as specialists might be most likely to see, for example, in hospital. So in the community balance of depression, it's like a big pyramid, with the most severe at the top being rarer and mild to moderate down the bottom being common. Right up at that top end of the pyramid, well, it's probably a triangle if it's unidimensional, but you know what I mean. Right up at the top of the triangle are the kind of people I might look after in hospital, where right now therapy is something they can only do in a limited way. But below that, we've now got evidence that therapy can assist. And generally in Australia, not universally, but generally, therapy is much more accessible than it used to be. I think while we debate, for example, the number of sessions available, it's worth remembering that before better access, accessing therapy was extraordinarily difficult. In terms of what type of therapy, we note that there's clear evidence that supports the key variable is finding a therapist that works for you and a form of therapy that works for you. To some degree, that might be influenced by the type of depression you have. What about online therapy? Because that's clearly a growing form, particularly to help meet people's needs, particularly if you live remotely. The evidence is a bit unclear because you can't do a randomized trial, can you? If you're getting online therapy, I think you know it's online. You can't blind that. It tends to say the trial evidence we've got, it works just as well. But we as a group said, oh, we're not sure about the quality of that evidence, and it's going to vary from person to person and situation to situation. So the jury's still out. Is online therapy with clinician support better than no therapy at all? Well, of course, of course. Which type of therapy? There are 6, and we use the term therapeutic brands, which might be a bit controversial, but 6 types of therapy that have the biggest body of evidence, and over 10 randomized controlled trials in acute treatment of depression. That's a lot of evidence. Of those, the 2 that had the most are CBT, cognitive behavioural therapy, and IPT, interpersonal therapy. And we also prioritise those because CBT in particular is probably the therapy that there's more therapists trained in Australia than any other. Again, I acknowledged that adding pharmacotherapy strengthens the effect. It doesn't say the other therapies don't work, and some critics of these guidelines, I think, kind of suggested we were saying that. That's not the case. It's just we have to go with the evidence. And it does depend on the person. There is evidence for certain types of cognitive behavioural therapy in the maintenance phase, and we'd really like to see more of that evidence for different types of therapy. because we really want to stop this being a recurrent disorder. Oh, sorry, just to go back, that point again, the evidence says combining meds, antidepressants as the usual initial meds, and therapy does increase the remission rate. Full stop. So the idea that they should be seen as sort of antagonistic in some way doesn't actually add up. You might have preferences, get that, but they're not enemies and shouldn't be seen that way. What about initial choice of antidepressant? Now, in the previous version of these guidelines and some other guidelines I've been involved in, like therapeutic guidelines, we often go first line, second line, third line. But actually the evidence to say we've got sufficient evidence of difference between them, and there's about 30 to choose from, is not so strong. We were heavily influenced by the most recent meta-analysis of antidepressants that I'll come to in a minute, that said if you balanced tolerability and efficacy, these 7 agents stood out as the best. They're not all the same for tolerability. So escitalopram, vortioxetine and argamelitine are more tolerable. Amitriptyline, an old tricyclic antidepressant, has an edge towards efficacy. We're not saying that means amitriptyline would be your first choice. Because of side effects and toxicity, it wouldn't be. It's saying, here are 7 frontline choices. If the first 7 you try, if you need to try 7, and God forbid, hopefully you don't, should some of these be in there? Well, yes, unless there's a very good reason you don't want to use one of these. Here, it's not escitalopram is a representative of all the SSRI antidepressants. It's escitalopram specifically. So that's kind of interesting. Does it mean the others, the other 23 that aren't on this slide, are useless? No. We're talking about relative advantages, and would it be nice if we were better at saying, for you, vortioxetine is definitely the one. I can tell. We're not that good at that. And that's a problem, isn't it? So it leads to some trial and error that ultimately I think we're hoping genetics will help us in predicting better and personalising the choice. This is the meta-analysis that we use to help us, and it's a bit complicated to look at this, I know. The top plot shows efficacy. In other words, how likely is each of those antidepressants to be better than placebo, which is the line in the middle. The good thing is they're all to the right, which says, yeah, they work better than placebo. Well, good thing. Otherwise, we shouldn't be using them, should we? What you don't see is all the antidepressants that didn't make it to market because they didn't differentiate from placebo. The bottom plot is tolerability as measured by dropping out from trials due to side effects. You can actually see there's a couple of antidepressants where it looks like less people drop out than placebo, which is kind of, really? That's interesting. Right down to some of the ones at the bottom, like clomipramine, a tricyclic, which is not so well tolerated. We kind of know that that can be a problem. This network meta-analysis involved about 100,000 patients in about 500 trials, so it's huge. When it was released, I did some media, including Stan Grant used to do a long-form program on the ABC, and I was on there with another person, and he said, so, Professor Hopwood, do you now believe that antidepressants work? And I must admit, my first mental response was, what sort of question is that? Thankfully, I didn't say that out loud. That probably wouldn't have been a good idea. But I think he was actually reflecting there is a lot of public skepticism about these medicines. I know that. And I was able to say this has confirmed my opinion that the ones we've got available do work. Not always. So each antidepressant has about a 40% remission rate if it's the first one chosen. Would it be better if that was higher? Yep. If you need a second one, the chance it'll work is only slightly low. It's about 35%. And by remission, I mean working fully. It drops down with the third and fourth one, not to zero. And actually, there's evidence that if we keep trying, we'll find one. But that would be better if it was more predictable straight away, wouldn't it? So yes, there's a need there, absolutely. And about 1/3 of people with depression fit into the category of what we call treatment-resistant depression, where two antidepressants haven't worked. And usually in Australia, if you've had two antidepressants, most, not everyone, have also had a bit of a go at therapy by then as well. And so they should. That's a good thing. Given that the first antidepressant doesn't always work, there's a real question, how do we work our way through this logically, trying to find the right thing for you? So if we start at number one, we give you a medication. With most medications, there's a range of doses that can work. And barring side effects, the usual response would be to increase the dose. So it's not wrong if your doctor's doing that. That's right. How long do you wait before increasing the dose? People often quote me, oh, it takes an antidepressant 6 to 8 weeks to work, doesn't it? Which is a long time if you're not feeling very well. Actually, we can usually predict, is it going to work before then? So if by 2 weeks on a given dose of a given antidepressant, nothing's happened, the chances it's going to happen at that dose of that drug is starting to get pretty low. So I will look at changing the dose at that point if nothing's happened. If you started to improve, then it can continue. And the 6 to 8 week thing is about the full benefit. Now, within that, there's lots of variations for different people, but that's a general principle. If that doesn't work, we then look at either switching to a different antidepressant, usually in Australia of a different class, or augmenting, adding in some of the things like mood stabilizers, or even some of the atypical antipsychotics that have been shown to boost antidepressants. And there we need to look at risk versus benefit of complicated regimes. At some point, and how early on depends upon severity, do we look at things like TMS and ECT? Off to the right there, yes. All the time over to the left, thinking about therapy, lifestyle, what's going on in your life, and have we actually got the diagnosis wrong? We should always be humble enough to think, well, hang on, are we missing something here? Do we need to rethink? Just a comment about all of the antidepressants available in that standard antidepressant space. And as you can see, there's a lot. Some of them you'll recognise, some of them you won't. The vast majority of them work in different ways on what are called monoamine transmitters, noradrenaline, serotonin, and some on dopamine. We have the first one that works predominantly on a different transmitter system, argamelodine, that works on melatonin. And that's a useful thing for some people. Some of the older ones have some effects on acetylcholine in the brain, a different transmitter system. Some of the tricyclics do that. That was always thought about more as a cause of side effects than of benefit, but we don't know. It might contribute to benefit. Ultimately, whenever they work, they increase the production of in the brain of what are called neurotrophins. BDNF, or brain-derived neurotrophic factor, is one of those. These are brain hormones that, when they're produced by neurons and glia in the brain, boost neuronal activity, neuronal survival, so you don't lose neurons, and neuronal sprouting, so they communicate with each other better. Producing neurotrophins and them working takes at least a week after you start taking a drug, whereas the receptor effects happen after one day. But they don't work after one day. That shows and fits with the idea that it's really this neurotrophin production that might be the important part of what they do. Now, a few comments about some of the new treatments, and I'll use new slightly in inverted commas. I'm getting very groovy, aren't I, using inverted commas? This slide discusses the evidence for cannabis or cannabidiol, medicinal or otherwise, in the treatment of major depression. Some of you may think, oh, Prof. Hopwood's got his colours wrong here. I can't see the writing. No, there is no writing. That's because there really is no high quality evidence that cannabis can treat major depression. And that's despite that idea being out there, isn't it? And I am seeing increasing numbers of people with depression who are either using cannabis regularly or getting medicinal cannabis. There isn't any evidence of benefit for depression. Cannabidiol, so there's two active ingredients in cannabis that you might buy from wherever you might buy it. One is THC, which is the part that can actually produce the weird and wonderful symptoms and probably increases the risk of psychosis. The other bit, cannabidiol, actually may have some potential utility, and there's a little bit of evidence in the treatment of anxiety disorders with cannabidiol. Given the crossover of depression and anxiety, if you're going to get prescribed cannabis, and clearly my general suggestion is save your money, don't ring up that cannabis clinic, but if you're going to, please get one that's predominantly cannabidiol, not pure cannabis. There is this one study that looked at patients who were prescribed cannabis in the UK. Now, you really had to be at severe end to get into this, and they weren't randomised to receive it. It showed some very minor improvements, but they were getting all sorts of other treatments at the same time. That's the extent of evidence. I'm really putting that up to say, good Lord, we need better studies. In this area particularly, this is not a well-evidenced treatment for depression. And I focus on that because a lot of people are doing it. What about ketamine? Because if you go to Depresso TikTok, or whatever the depression bit of TikTok might be called, you will see a lot of discussion of both ketamine and the psychedelics. What level of evidence do we have about them? So this was the very first study of ketamine in major depression. So what is ketamine, first of all? It was first used as a human anaesthetic. It's often described in the papers as a horse tranquilizer, and I don't think that's a compliment, is it, calling something a horse tranquilizer? It is a human anaesthetic and is still used, particularly in paediatrics. We've known for a long time at those much higher doses, it can affect mood in variable ways, actually. So nearly 20 years ago now at NIMH in the US, they did trials with a single dose of intravenous ketamine for people with treatment-resistant depression. And lo and behold, found this rapid response where a proportion of them got better within an hour or two. By the end of a week, most of them were back to baseline. Well, how useful is that is a question. So we've moved to investigating, first of all, some more effective and efficient ways of giving it, and also what is it that works in it, and is there value in giving it repeatedly like we do with most things. We now have, as of 1st of May this year, esketamine on the pharmaceutical benefits scheme. And this is one of the studies that supported that. So esketamine is an isomer of ketamine. If you look at ketamine under a microscope, it comes in left and right-hand molecule versions. And this is the purified left-hand version, which particularly binds well to the relevant glutamate receptor in the brain. That's how we think ketamine works. There's some debate about that, but that's how we think it works. It's a treatment proposed for treatment-resistant depression. That's for a few reasons. It's expensive, and you've got to go to a treatment centre to have it, because you get observed for changes in blood pressure and dissociation for an hour or so post-dose. So that's quite a hassle, right? And that means we don't use it first line. In these studies, it was combined with the new antidepressant, and people either got the new antidepressant plus placebo or plus esketamine. And in this study, it clearly proves superior. Not all studies were positive, but working in that difficult to treat space is quite complicated. So we think this is now a well-evidenced treatment. And obviously, the pharmaceutical benefit scheme, eventually, they have thought about a number of times, reached that conclusion as well. I have no doubt part of the barrier was it's relatively expensive compared to other antidepressants, and I accept the pharmaceutical benefits should look at value for these things. But for me, as a clinician trying to help people with depression, new options are incredibly valuable. And this one is the best evidence to the ones I'm going to talk about. So as I said, it works to enhance glutamate in the brain. Glutamate is the most widespread excitatory transmitter in the brain. That is, a transmitter that stimulates other neurons. So it kind of sounds like that should be a good thing in depression, right? And the parts of the brain that we know are relevant to depression are pretty rich in glutamate and its receptors. So it makes intuitive sense. Esketamine is delivered via a nasal spray that looks just like this one. This one is a mock-up, so there's no esketamine in it. And you administer that on site, and there's a dose range. We start at 28 for older people, but most adults start at 56. You have bi-weekly treatment for 4 weeks, and then we continue for a 6-month maintenance period if it worked. No point continuing maintenance if it didn't work. It's time to move on to something else. Now, there is still an expense attached to this treatment unless you can get into a trial for the nursing supervision and pharmacy, because it's a Schedule 8 drug. It's restricted because it is potentially a drug of abuse, albeit this is a very low dose and abuse doesn't seem like a problem with this kind of use. But I suppose people could divert it in theory. And that cost is not small. It's, depending on where you go, $300 to $400 per treatment. And that's a barrier, and I don't like that there's a barrier of cost, but it's important to be upfront about that, right? But nevertheless, it's an evidence-based new treatment. We've published some data from our use of it at Albert Road Clinic, and we had initially some people who were entered into our trials who really were very treatment resistant and tried a lot of things. And pleasingly in those, we saw response, not for everyone. And I think with new treatments, we really need to be honest about response rates, because it's new, it can kind of, people get a bit excited, don't they, and are very hopeful about it. The big trials were in people who'd failed 2 or 3 antidepressants, and there the response rate was 50%, which compared to trialling another traditional antidepressant is probably 2 or 3 times better. So good, that's good. In the patients we saw who'd often tried about 7 or 8 treatments on average, the remission rate was a bit over 30%, about 1 in 3. So that's a bit lower. Now, that's not surprising. The more treatments you've tried, the lower the response rate to the next treatment. But that's still a lot better than most other things in that space. So we think this is a useful treatment. I'm just going to close this section with a quick comment about psychedelics. And the main thing I want to say here is that at this level, at this time, it does not have the same level of evidence as esketamine or ketamine, and does not have, in my view, or that of the College of Psychiatrists, enough evidence for this to be a routine practice. Now, our Therapeutic Goods Administration surprised everyone in Australia by making it registered, not funded, but registered in Australia about 3 or 4 years ago now. And it kind of caught everyone by surprise. Normally, our TGA is conservative. They were the first group in the world to do it, and still one of only a couple. Nowhere in the world is it routinely funded, and the FDA in the United States recently knocked it back for registration. So there's a lot of debate about this area still. In depression, the main compound that's been investigated is psilocybin, which some of you in the audience may know is the key ingredient in magic mushrooms. Some of you may not know, I don't know. And the idea with psychedelic use was originally that you take the psychedelic and that helps break down barriers in your thinking or around discussion of things that are contributing to your depression in this case. And we certainly know for some people that's a real barrier, that's true. It's not clear, is that talking under the influence of psilocybin or before or after you have the treatment with the insights you get? There's a bit of debate about that. This was one of the pivotal studies in depression done by the group at Oxford, comparing psilocybin to a standard antidepressant, escitalopram. So one of the ones we said you might use early on. Statistically, at the end of the study, 7 weeks, they were identical in outcome. Both produced significant improvement. And psilocybin here was given on 2 occasions to people with associated therapy. Numerically, psilocybin was better, but overall, they statistically weren't different. There is a question there, though. And this was one the FDA asked. Were patients blinded in this study? Well, I think if you take magic mushrooms, you probably know. So you can't be blinded so easily. It's just a reality. It's not a criticism. It's just a reality. So there's a bit of debate about it. Interestingly, the bottom part of this graph shows improvement in an instrument that measures certain aspects of psychological insightfulness and the kind of insight that psychedelics are meant to bring to some people. And psilocybin clearly outperformed escitalopram on that scale. Is that important? Maybe. There's a lot we need to learn. There's a second study, a German study, looking at psilocybin that did show separation compared to placebo. It was small. This was more in treatment-resistant depression here now. What does that tell us overall? It probably tells us there's something worth really knowing about here. And I don't want to sound like I'm a critic of the whole area. If we added up the well-controlled, with the issue of blinding, but the well-controlled studies with psilocybin in major depression, overall we're still talking about a few hundred people. Traditional antidepressants, to get them up and registered and funded, you'd need probably a sample of about 3,000. So you could say that says early days. And I think particularly with the treatment, we're not quite sure how best to use yet. So a fundamental question is, if it works, is that just because it's a different type of drug? It has effects on the serotonin system. Is the therapy what matters? If it's the therapy, is it the therapy under the influence or afterwards? I don't think we fully know the answers to those questions yet. There's a lot of ideas and some strong opinions about it, but I think there's still a lot we need to learn. There's probably also a little bit of caution about for whom. So certainly at this stage, we'd all be saying not for psychotic depression or if you've got a family or personal history of psychosis. No way. Now currently, this is not funded. And combining the cost of the drug with the therapy sessions, Those places that are offering it commercially are doing a small amount of business because it comes out at about 25,000 for a course of treatment. You know, wow, that's a lot of money for most people. I'm sure there's some who it's not a problem for, but not many, right? So we don't yet know where the future of this fully lies. Is there enough of a signal that we want to know? Yes. So may this ultimately fit into our pathway? Yes. But at this moment, it's right at the far end, in my view. And that's important because depending where you read stuff, it can sound like this should be the thing you have first, straight away. And I don't personally think that's right. All right, I'm going to stop sharing at that point. I've ranted on for long enough, and that should leave a few minutes for questions.
Um,
Now, I see there's some in the chat if we like. I know it's a good morning.
yeah. So thank you so much, Professor Malcolm Hopwood, for presenting a very informative presentation on depression and show us like the development in the field. So here we've got one question from the audience.
Great.
Yes, how can clinicians ensure that potential undiagnosed neurodivergence isn't overlooked when someone is diagnosed with depression and begins antidepressant medication?
Yeah, great question. Thank you, Rachel. I'm not sure. I got a question sent to me before the webinar. Whether it's the same question, I'm not sure, because it did touch on neurodivergence. And look, I think there's a couple of ways of thinking about this. And the first thing to say is neurodivergence, including autism, is a problem we've got growing awareness of in our community. And it's important to acknowledge that I don't see that as exclusionary of depression, but rather a risk factor. If we think about the ways it impacts life, it's going to be a risk factor for depression. That interplay is complex. It doesn't mean everyone with autism or ADHD, for that matter, has depression. That's simply not true. But it means we need to think carefully about the possibility and work our way through it. Some of the classic symptoms of depression may vary in how they present in this setting, and I'm often really keen to track what's different compared to the way you are when you're going well. You know, trying to personalise it a little bit in that sense to identify difference. But I think a really important part is having it in the back of my mind, I need to think about the possibility you could be depressed, and have that as an option. Of course, inappropriate treatment on a kind of women of prayer, it might be depression, needs to be acknowledged as just that. If treatment doesn't help, don't keep it going. I think that would be a good tidy up rule, wouldn't it? A couple of the other questions that came through, I might just link to that. These were pre-sent to me. A person, possibly I suspect with neurodivergence, mentioned the struggle to manage that and the risk of anxiety and depression. And I absolutely accept and think that's right. And that's why it's really important, I think, to be looking at things like early intervention, thinking about the environments we live and work in and our relationships, and appropriately tailored support for people with things like autism and ADHD from people who perhaps have some understanding of what those conditions might be like and how they can affect life. I can't begin to list the number of times where I've heard someone say, look, once I got onto a therapist who clearly seemed to understand my autism better, they could suddenly identify what was going wrong. And I hadn't previously been able to do it myself, but it made such a difference. And I think that's a really important thing. Just a couple of those other questions. There's a couple about adolescence in the questions I got sent before. And one of them is the classic one about antidepressants in adolescence. And I'll try and make the answer short. I know we're at time. The evidence about antidepressants in adolescence is still limited. Unfortunately, some of it's not positive, as in they don't seem to work as well. Whether the main problem there is we're not always good at knowing what depression in adolescence looks like because it's such a turbulent time, might be part of the problem. The best evidence in adolescence is with fluoxetine of all the antidepressants. So generally that should be the one we use first. There's another question about helping someone with depression, including if they've got suicidal thoughts. And I'll close with this one because it's a really important thing. I think for everyone suffering from depression, there's a group of people around them who struggle along with that person. That's important to acknowledge the challenge that brings and the impact and the risk for depression in families, for example. I think often I meet family members who are desperate to do everything they can to help. And, that's the general place people start with. And I think one of the important things is to know it's not your fault, mum, dad, brother, sister, partner. And it would be great if you could cure it through your efforts alone. You can definitely help, but most of the time, you can't cure it. It's not your fault. Support as best you can is all you can do. So don't drive yourself into the ground with guilt about that. Encourage a person to get assistance and be an active part of that assistance. So in my care, often communicating regularly with family members is very important and helping them with tips. I'll close with suicidality is, of course, one of the most difficult issues to discuss in depression. And in particular, when it comes up, how do I know whether to take that urgently or how do I deal with that? And I want to start by acknowledging how tough and difficult that is for both the person and the family. But I think the message here is if a person's having those kind of thoughts, that is a signal, surely. Judging for certain how high the risk is really tough and complicated. I don't expect either the person with depression or families to get into that by themselves. If that comes up, surely that's a flag. It's time to get help. And I think that's probably the key message I'd say. I'm sorry to have gone to 1:03.
Oh, thank you so much, Professor Malcolm Hopwood, for answering questions from our audience and your excellent presentation. That's very informative. Yeah. So now I'd like to take a moment to thank each and every one of you for joining us on our today's highly informative webinar on depression. So thank you. Goodbye for now.